So we start with obesity and anesthesia. Overview of this is first, how do you define obesity? Common comorbidities that you see in obesity. What are all the system-wise involvement because of obesity? What is the pathophysiology? What are the anthropometric measures you do for defining obesity? And all about OSA and metabolic syndrome. What are the drug dosing principles? What are the challenges in anesthetic management? And what are all the clinical situations where you may encounter an obese patient? So this is all the subdivisions on this topic which we can discuss this. How do you define obesity? What is the definition of obesity?
Increase in body weight, and body weight exceeds greater than 10% of the ideal body weight.
Which book is giving this definition? So obesity is defined as an abnormally high amount of adipose tissue compared to lean muscle mass, or 20% more of ideal body weight, not 10%. Okay. Enumerate the comorbidities associated with obesity. It can be diabetes, hypertension, coronary artery disease, or decreased life expectancy. Now mention the medical and surgical conditions associated with obesity in a system-wise manner. So that is the next question. So coming to respiratory system, it can be obstructive sleep apnea, obesity hypoventilation syndrome, or they may have simple restrictive lung disease because of the chest fat and compressing the thoracic cage. In the cardiovascular system, they can have systemic hypertension, coronary artery disease, congestive heart failure, peripheral vascular disease, pulmonary hypertension, hypercholesterolemia, hypertriglyceridemia, and the metabolic syndrome with sudden death. Coming to endocrine, that can be metabolic syndrome, diabetes mellitus, sometimes they may have Cushing's or hypothyroidism. The GI tract, they can have non-alcoholic steatohepatitis. Hiatus hernias are very common. They can have gallstones and fatty liver, GERD, delayed gastric emptying. All these things are very common. That's why we have to always give all the obese patients anti-aspiration prophylaxis. And musculoskeletal, they can have osteoarthritis, backache, and inguinal hernia and joint pain. So OA patients, if their restricted mobility is there, so you cannot assess the effort tolerance correctly in the elderly obese patients coming. So for example, a 70-year-old lady who is morbidly obese coming for TKR because of osteoarthritis, you cannot assess the effort tolerance by asking her how much you walk, are you able to climb flight of stairs. So how do you assess the cardiac function in that patient if they have a musculoskeletal problem? You have to go for
testing.
Pharmacologically induced stress test. Okay, so dibutamin stress test is the common thing that they perform because they cannot do any exercise. And malignancies are common in obese patients in the pancreas, kidney, breast, prostate, cervix, uterus, colorectal. All these things are very common. Other problems that can happen is renal failure, depression, and reduced life expectancy. Now, how does obesity happen? What is the pathophysiology? First thing is the BMR. Obesity is primarily an imbalance between energy intake and energy expenditure. So overeating and more sedentary life with less exercise is the first and foremost cause. Energy expenditure is mainly by basal metabolic rate within lean tissues, that is muscle mass. And regular exercise increases BMR and energy expenditure. That is how the exercises help. But fasting without exercise decreases BMR, but weight gain will be, the slow weight gain will be due to less expenditure when normal intake is resumed. So Patients who don't do proper exercise but just cut down on weight, they will again gain weight if they don't do proper energy expenditure. And fast storage becomes positive, and it is the triglycerides which are stored as an energy base for all the persons. And BMI 40 kg only increases up to 40 kg of BMI, the fat cells only increase in their size. But in severe morbid obesity, they increase in their number also. Otherwise, the adipose tissue number is the same. And there are the enzymes activity in the abdominal fat is more compared to the hip fat, and also the inflammatory response is more. So that is why the central obesity is considered more dangerous. If there is more of abdominal fat distribution, it's called android, and if it is peripheral, it's called gynecoid. And the waist to hip ratio of more than 1 in male and more than 0.08 in female carry a higher risk for ischemic heart disease, stroke, diabetes, and sudden death. So this is one important calculation that we have to make. And stress and cigarette smoking stimulate cortisol production, which enhances deposition of abdominal fat. So patients who smoke a lot, they can develop obesity. Coming to cellular disturbances, it occurs due to alteration in insulin function, the decrease in insulin secretion due to fatty infiltration of pancreas, and also patients develop insulin resistance. And in the adipocytes, increased number of cytokines, interleukin 1, 6, and TNF-alpha, they are all increased. And there is a decreased secretion of another hormone called adiponectin, which is a powerful insulin sensitizer. So because of the decrease in adiponectin only, insulin is not able to carry out its normal action. And another hormone secreted is leptin, which is a hormone of satiety. So when there is a decreased leptin production, the patients don't feel happy or comfortable after eating. They want to eat more and more. They don't feel full at all. So the absence of leptin causes absence of satiety, which is the reason for their overeating. And there is a hormone to create hunger or to stimulate hunger, that is called ghrelin, which modulates appetite by central and peripheral mechanisms. So the imbalance between ghrelin and leptin is one of the important reasons for obesity. And there can be genetic mutations where hypothalamic melanocortin receptors are altered, which can cause, especially in childhood obesity, where children go on munching something. That too, nowadays with the junk food that is available in plenty, childhood obesity is becoming a big problem. So homozygous mutations in genes of leptin and ghrelin is also one of the genetic factors. That is why in some families, all the people will be obese. The entire family, father, mother, children and grandchildren, everybody will be obese. That is all because of the genetic factor of this particular two hormones. And environmental factors is intake of high calories and decreased physical activity. And psychological and socioeconomic factors, binge eating and disorders and night eating syndromes, especially in students, keeping awake late in the night. So you feel hungry and start eating something at 2 a.m. and 3 a.m. Nowadays, all the Zomato and Swiggy are ready to serve you at any time of the day. So you are ordering and eating. And depression also leads to overeating. So some people overcome their depression by keeping on eating also. And marketing strategies which sell oversized food packets lead to overeating. This is another thing. Measures, how you measure them is ideal body weight, also known as Broca's index, where height in centimeters minus 100 for men and 105 for women. BMI is also called Quetelet's index, weight in kilogram divided by height in meter square. Lean body mass is the ideal body weight plus 20% what the weight. So how do you classify BMI? That already he has explained. Less than 18.5 underweight, 18.5 to 24 normal, 25 to 30 overweight, 30 and above becomes obesity class 1, class 2, like that. Then waist circumference is also nowadays taken as more than 102 in male and more than 88 in female. And waist to hip ratio more than 1 in male and more than 0.8 in female is considered important for assessing the abdominal metabolic problem. Then tricep skin fold is a measure. This is how it is measured. You pinch the skin and then use this particular instrument. There is a name for this instrument which is called Harpenden calipers. Okay, this caliper is used to measure the skin thickness. And then clinical criteria to make a diagnosis of metabolic syndrome. In all cases of central or abdominal obesity, please remember that you have to rule out metabolic syndrome in that patient before they are taken up for surgery. Especially nowadays, a lot of patients are coming for bariatric procedures to weight reduction as a main treatment for obesity. So in that patient, it is always a must that you rule out metabolic syndrome to avoid what I told you as an important complication of sudden unexplained death. All the things seem to be going normal. Suddenly on the day of discharge or one day before discharge, they may suddenly die. So this metabolic syndrome consists of abdominal obesity, triglycerides, high density lipoprotein, blood pressure, and fasting glucose. So any three of these five will indicative of metabolic syndrome. So with the investigations, you have to make a mention whether the patient belongs to metabolic syndrome or not. Then comes the obstructive sleep apnea, episodic cessation of airflow. That is the definition for obstructive sleep apnea is it is episodic cessation of airflow for more than 10 seconds. But in obstructive sleep, there is only a 50% reduction in the airflow, which is called hypopnea. So obstruction apnea is total cessation, whereas in hypopnea, there is only a 50% reduction. If it happens more than 5 times per hour or 30 times in a night, it is significant. And stop bank questionnaire helps to identify this condition. For the alternate for this is the Berlin questionnaire. And OSA is classified as central and peripheral. And central is due to stroke, drugs, alcoholism, and peripheral is mainly because of obesity, or in children it may be because of the tonsils and adenoids, causing a reduction in the pharyngeal cavity. The investigations needed for OSA is overnight polysomnography. What is the other name for that? This is the technical term, overnight polysomnography. What is the simple layman's term?
Sleep.
It is called sleep study. Very good. It is called sleep study, and you have to do a complete blood count, EKG, and the treatment initially is lifestyle modification, weight reduction, and if it is not controlled with that, you have to go for CPAP and BiPAP. What is the difference between CPAP and BiPAP?
CPAP is same continuous positive airway pressure throughout inspiration and expiration, sir.
Very good.
BiPAP, different pressures are applied during inspiration and expiration.
Very good. So it will be more during inspiration and less during expiration is BiPAP. Whereas the same pressure both during inspiration and expiration is CPAP. So if a patient says, I am not comfortable using CPAP, then you have to go for BiPAP because he is not able to breathe out by the positive pressure. So the main idea of giving this positive pressure is to splint open the collapsed pharyngeal airways, okay, because of the laxity of fat deposition. When the patient loses consciousness after sleeping, the pharyngeal muscles collapse, so the airway becomes narrow. So initially it reflects as snoring. Then it starts completely occluding, producing the obstruction. So the CPAP keeps this upper airway open, so they feel comfortable breathing in and out. But if they feel difficult to expel out the expired air, then you have to reduce that pressure applied during the expiration. Then it becomes a BiPAP machine. What surgeries can be done for treatment. Sometimes they may ask you what are all the available surgeries.
Uvulopalatopharyngography.
Very good.
Uvulopalatopharyngoplasty.
Tonsillectomy, adenoidectomy in children. All these things will help in overcoming this obstruction. Okay, so surgeries are done. Sometimes in very severe cases, they have even resorted to tracheostomy. Okay, as a permanent measure. Then anesthetic risks are, they are very sensitive to narcotics, and they desaturate very easily. And the long term, they can go for biventricular failure because the pulmonary hypertension will develop and the right heart will start failing. And because of obesity, they will have left heart failure. So they may go for biventricular failure also. Now coming to the stop bank question, all these points was explained by Arul, and how you find out the severity of this is based on the stop bank questionnaire. Then there is something called Epworth Sleepiness Scale. This is mainly for assessing the severity of daytime sleepiness. So based on whether asking these questions, do you fall sleepy, or do you fall asleep while sitting and reading or watching television or sitting in a public place? And majority of the students start sleeping when the class is going on. That is not coming under this category. Okay, lying down to rest in the afternoon, sitting and talking to someone, do you fall asleep? Or sitting quietly after lunch, do you feel sleepy? Some people have a tendency to fall asleep when their car stops in a traffic signal. Okay, that is a very common problem. Some accidents also can happen. So all these things are classified into Epworth Sleepiness Scale, and based on the severity, you have to take more aggressive action to correct the OSA. Okay, so that is the use of this Epworth. This is one of the short note questions that can come in your theory paper, ESS or Epworth Sleepiness Scale, and its importance. It is important to treat the OSA aggressively if they have this problem. Now this is the Berlin questionnaire, which is something like a modification of the Storm Bag question, and this is the disposition of lean body mass and adipose tissue in a normal patient compared to the obese patient. In obese patient, it is 40% to 60%, whereas normal it should be 80 to 20%. So there is an increase of 20% in the body weight. From 20 it becomes 40. Okay, so ideal increase of 20% of more of fat compared to the normal level. So some drugs are lipid soluble, some drugs are water soluble. So because of lipid soluble nature, there is an increase in volume of distribution in obese patient because of more lipid is there. Large loading doses required to reach the plasma concentration, and so all the drugs which are lipid soluble should be based on actual body weight. Whereas water soluble, there is a limited volume of distribution. The volume load is less, so not influenced by fat stores, so based on ideal body weight. So water soluble drugs to be given on ideal body weight, fat soluble drugs to be given on total body weight. Now calculating the dose of the drug, how you do that, all these things are available in the books. So this will help you. What drugs you can give as a total body weight, you have to use propofol. As a loading dose, you have to give total body weight. Whereas if you are going to give the infusion, you go on lean body weight, not on ideal body weight, but lean body weight. Midazolam, you go on total body weight. Thiopentone, you go on lean body weight. Saxamethonium, total body weight. Vecronium, only on lean body weight. Suzetracurium, atracurium, loading dose on total body weight. When you use it as an infusion, you go on lean body weight. Pancuronium, again total body weight, and other drugs like remifentanil, fentanyl, sufentanil, all have to be given only on lean body weight. Vascular access may be a challenge in obese patients, so you have to use a good cannula. Sometimes it may require central line because of non-availability of peripheral line, and that should always be done with the ultrasound guidance. And volume replacement in obese, adult total body water percentage is 70% in normal individual. But in a severely obese patient, body water is reduced to 40%. So ideal will be to pay, so they don't tolerate faster fluid and blood loss during surgery. So you have to be very watchful. So in a volume replacement, what you follow is avoid rapid rehydration to lessen cardiopulmonary compromise. Administer hetastarch at recommended volumes per kilogram of ideal body weight. Albumin and 25%, 5% are used to support circulatory system, and replace blood loss with crystalloids at the ratio of 3:1 as you do for other patients. And fluid replacement in obese patients should be based on lean body weight and not on total body weight. That is another important thing that you have to remember. And what are the challenges? You can remember by this mnemonic, a prime minister at a public function. Okay, this is a mnemonic by which I remember the challenges that you are going to face in an obese patient. A for airway. So you have to make a thorough assessment of the airway and decide well in advance whether you are going to plan for a awake fiber optic intubation or a asleep induction intubation. So if you are going to do an asleep induction intubation, you have to have a good support, and also all the airway cart and other positioning and everything should be meticulously planned. That is a very, very important. That is why that is given the first priority of the challenge in obese patient. So detailed evaluation and planning essential, including awake intubation. The next comes the position. The Prime Minister P stands for position. So head up during induction and recovery, and RAM position or head elevated position for intubation. Monitors is the third challenge. So NIBP cuff, EKG tracing. Sometimes if proper reading cannot be taken by indirect method, you may have to resort to the arterial line for measuring the blood pressure. And SpO2, EtCO2, temperature are all very important for these patients. Then the agents that you are going to use, what are the drugs you have to use, and you have to calculate and keep the dosages ready, and what volatile anesthetic agent is safe, how much of neuromuscular blocking drugs you are going to use. Everything should be well planned before you start the case. What is the technique that you want to do is difficult IV access may be there, and central line also may be difficult, but it has to be done. And wherever regional anesthesia is possible, like a plexus block or a central neuraxial blockade, that you can give. But make sure that the surgery can be finished within the limited time of the regional block. Otherwise, if sometimes you'll end up with a prolongation of the surgery and you need to convert it to general anesthesia. Unless you are confident about securing the airway, you cannot just like that casually give regional for all the cases. So you have to be very, very watchful in that. And with regard to pain relief, careful use of narcotics, especially in OSA, and multimodal analgesia is the thing that is we are practicing now. And lastly, fluids, that replacement on lean body weight basis, and avoid rapid filling. Okay, so this is the mnemonic, a prime minister at a public function, airway, position, monitors, agents, technique, pain relief, fluids. So if you remember all these 7 points, you will be able to manage a obese patient. Now, clinical situations encountered, some of the examples. One of the 62-year-old female lady with 130 kg, height 5.2, 5 inches to 5 feet 2 inches, had a fall and suffered a fracture in her right wrist. Needs reduction with a K-wire insertion. How will you anesthetize this patient? Any idea? This is one of the clinical situations that you can get in the exam as a theory question, or in sometimes in the scenario also can be given.
Go for axillary block, sir.
So first of all, is it an emergency, a fracture in the wrist? Is it an urgent thing that you should do whether the patient is in full stomach or not? Wrist fracture is not a life-threatening emergency, isn't it? So first thing you always assess in emergency whenever the patient is referred is whether the patient is in full stomach, or we can wait for the prevent the aspiration problem by starving the patient adequately, and that can be taken as an elective patient also. Okay, so unless there is a vascular compromise, a wrist fracture like a Colles fracture is not an emergency. You can always give a splint and wait and take up. But the height and weight indicates that the patient may be morbidly obese. So even if you can manage this in the regional block, like axillary block, as you said, first and foremost, assess the airway. So in case you have a problem, if the axillary block fails, or the surgeon takes more time, suddenly he decides I will open and put a plate instead of K-wire because it is not aligning properly, and it is going to take 3.5 hours, 4 hours, your axillary block is going to wear off, then you are in trouble. So always, as I said, make sure that you can secure a safe airway in these patients by a proper evaluation of the airway, and then you can plan for a regional technique. The second scenario is a 57 years old male smoker, history of COPD, diagnosed with CA rectum, posted for anterior resection. His BMI is 38 kg per meter square, which is on the what grade of obesity? Grade 2, 35 to 40. He is treated for OSA with a BiPAP machine, pressures of 10 centimeters and 7 centimeters for the past 7 years. What investigations are needed? How do you optimize this patient? What problems to be anticipated and managed during perioperative period? So it's a major procedure. CA rectum, you cannot wait. So you must quickly optimize the patient, and you have to take up the patient for that. So what will be a best method in this patient? Just roughly tell me the anesthetic management, not details.
General anesthesia.
General anesthesia only?
Sure. General anesthesia.
Only general anesthesia or something else added to that?
Epidural.
Combined general with epidural. Okay. Even though epidural may be challenging in the obese patient, if you can achieve a epidural catheter, you can place it, means nothing like that. You can avoid too much of narcotics and all that. And you can give a very good post-operative pain relief so that you can mobilize the patient faster and you can make him do all the breathing exercise, everything. So a combined general anesthesia with an epidural catheter in situ will be the best method of managing. Okay. And the last is 24 years female with a BMI of 42 wants to undergo weight reduction surgery since all conservative methods failed. She has been diagnosed to have diabetes and hyperlipidemia. How to proceed? So BMI is 42 is more than grade 3, isn't it? Grade 1, grade 2, grade 3, and mainly a bariatric procedure. So again, all the problems or all the procedures that I said. Intraoperatively, what is the name of the surgery that is done for weight reduction? Because bariatric underweight, what are all the other technical terminologies that are used for the liposuction is reducing the abdominal external fat.
Gastric restrictive procedures, sir.
Sleeve resection. It is called sleeve resection of the gastric stomach. I mean, stomach sleeve resection or bypass. You bypass the stomach and directly send the food to the small intestine.
Roux-en-Y gastric.
Yeah. So one complication of that, what is supposing intraoperatively during bariatric surgery, suddenly the patient desaturates and there is a hyperresonance in the chest. What does it indicate?
Pneumothorax.
Pneumothorax. Yeah. So through the diaphragm they can damage and produce a pneumothorax. Okay, right. So now management of this 62-year-old geriatric patient, BMI. So here there are two problems. Patient is obese and she belongs to geriatric age group. BMI works up to be 52.3, which is morbid obesity. Nature of the surgery, it is a non-emergent surgery. And pre-op assessment, airway assessment is very important. And find out any history of OSA and comorbidities like ischemic heart disease, diabetes, hypertension, bronchial asthma to be ruled out, GART, and check the effort tolerance and see the landmarks for regional as well as for the so since surgery is not emergent one, can advise pre-op starvation and do it as an elective. Anesthetic choice of anesthesia is RA preferred over GA. So the RA choices are, can be a brachial plexus or an axillary block or IVRA or LA into the wrist hematoma and all these things. For 1 and 2, that is a brachial plexus and axillary block, you can use ultrasound for better results. GA, for all preparations of difficult airway to be done, have senior help and calculate all the drugs. Pre-oxygenation very important, RAM position for intubation. Avoid too much of opioids and extubation in head-up position. Usually done as a daycare procedure through thorough pre-op evaluation is very important, as you may have to discharge the patient the same day. All facilities of admission is needed in case of any complication, which must be informed to the patient while getting consent. So you must tell the patient that we usually do it as a day case, but in case of problem, you may have to stay overnight. That also you have to keep in mind. The second problem case is obesity, COPD due to smoking, OSA on BiPAP, and malignancy. These are the 4 common challenges. So that's what I told you in every case, whether it is in theory paper or in practice, practical exam, you always sort out the problems. Like in this case, there are 4 problems: obesity, COPD, OSA, malignancy. So based on that, pre-op evaluation of CVS for hypertension, ischemic heart disease, RS for severity of COPD, and what treatment he has been taking, what is the effort tolerance, how much of lung function is there, airway assessment, and plan for securing the airway, whether awake, fiber optic, or induction and paralysis, smoking cessation, respiratory exercises, and any plan for enhanced recovery after anesthesia, because nowadays all the colorectal malignancies are done on a enhanced recovery ERAS procedure. So that has to be discussed with the surgeon. And plan of anesthesia will be combined spinal with epidural. Okay, so GA with epidural or a tab block or paravertebral block also can be combined. And remember the mnemonic APNEA TPF, that is airway position, monitors, agents, technique, pain relief, fluids. And for the third case of bariatric surgery, mostly done by laparoscopic technique. So young patient usually will not have much of a problem, but obesity and DM are the problem. So assess airway and ask for history of OSA, control glycemic status, because the patient is a diabetic. Adequate glycemic control is important. Same rule can be all the mnemonics you can remember, plus the technique that is recommended is a combination of dexmedetomidine ketamine infusion during operative procedure for GA. Mostly somehow people don't use regional techniques along with for bariatric procedure. I don't know why, but generally not advocated. And in obese parturient, the anesthetic challenges it should be managed as a multidisciplinary team in HL. Neuraxial analgesia should be offered early in labor. And continuous neuraxial techniques are optimal for cesarean delivery. General anesthesia poses significant risk in these high-risk patients. And maternal and neonatal complications with obesity, there are multiple ones which are there. And coming to the patient with laparoscopic cholecystectomy in obesity, you first classify the anesthetic challenges into problems due to obesity and problems inherent in laparoscopic surgery. Now the laparoscopy, these are the problems: intra-abdominal pressure increase, the CVS effects due to raised IAP, RS effects due to raised IAP, hepatic effects, renal effects, and position-related problems, what are all the intraoperative respiratory complications that can happen, and anesthetic modifications that are needed from the conventional type of anesthesia which you give for other laparotomy and other procedures. Now, the placement of Veress needle. This is the Veress needle. All of you would have seen how they pinch the abdomen and then try to introduce it. And through this needle, they insufflate first initially and then put the what is called the trocar. Okay. So this needle carries the risk of sometimes going down into one of the vessels, and without knowing they will be insufflating, and gas embolism is very, very common during this initial stage. So you have to be very vigilant when the surgeon is doing this. So intra-abdominal bleeding or gas embolism are the two important complications which may make the patient collapse at the very beginning of the surgery. So you have to be very watchful. Some surgeons, in order to avoid this blind insertion and getting into problem, do what is called open laparoscopic access, which is called Hassan technique, where they make an incision, a small incision, and then retract and then directly put the trocar. Instead of using the Veress needle, they make an incision sufficient enough to introduce the trocar. This is the trocar with the obturator in situ. This is a blunt one, and they introduce that and then start insufflating. And the third method, can anyone name what is this method? There you can see a light here. As he is introducing the trocar, there is a light going on and there is a cable here. Can anyone name what is this technique? This is called the optical view trocar insertion. So they introduce a small camera with an optical light, and then they can see the layers going through the various layers. So this is a much more safer. Under vision, they can see the skin, then the subcutaneous tissue, then the rectus sheath, the muscle, whatever they are piercing, they will be able to watch it from the camera and it will be displayed in the monitor. This is the newer method to avoid unnecessary injury. So this is called optical view trocar. Now what are these things? It's a laparoscopic ports. They are called ports. Okay, so these are the port sites for lap chole. The first port will be put here, which is a 10 mm access port. Then they will put a 5 mm here and a 5 mm. This is called the left hand working port. This is called the fundus grasper port. Sometimes they may put another port if necessary here, the fourth port, but usually they stop with the third port. And one of the methods of producing good analgesia is to infiltrate these port incision sites with a bupivacaine 0.25% right before the ports are introduced. And lastly, after completion of surgery, some surgeons instill 20 ml of 0.25% bupivacaine into the peritoneal cavity and the gallbladder bed in cholecystectomy especially, which produces very good analgesia. So compared to using other methods, this is a very good procedure by which you can give a good pain for post-operative pain relief. And intra-lung recruitment maneuvers, this question can be sometimes asked, what you do to prevent desaturation because of some atelectasis if you diagnose. So you can give 40 centimeters of positive pressure for 30 seconds. You must usually use only pressure controlled ventilation. Whenever you, especially in the obesity patients, you use pressure controlled ventilation. Whereas in a normal adult, we prefer volume control. So set the respiratory rate 0 and turn off the apnea alarm. Increase PEEP to 40 centimeters for 40 seconds. And most recruitment occurs in the first seconds. After that, you may have a hemodynamic instability. So this is not a very popular method. Then you can use the sigh mechanism that is there in the ventilators. So 3 consecutive sighs with a plateau pressure of 45 centimeters, that also you can give. Then 2-minute peak pressure at 50 centimeters of water, and the PEEP after that is also used. Then long slow increase in inspiratory pressure to 40 centimeters, which is called the ramp maneuver. and stepwise increase, which is called the staircase recruitment maneuver. This is one of the short note questions that you may be asked in the examination. Staircase, especially in the ARDS. The indications for lung recruitment maneuvers are mainly, these are all borrowed from the treatment of ARDS patients with very resistant hypoxemia. In those cases, they have tried all these things, and this is now being extrapolated and used in obese patients undergoing general anesthesia. And recruitment maneuvers sometimes may be needed after applying suction or in cardiogenic pulmonary edema also. Okay, so these are the indications. And if you see the staircase recruitment maneuver, this is happening. First, there is a 10 centimeter PEEP, and you gradually go on increasing the PEEP up to 40 centimeters and maintain it for quite some time, and then start decreasing it. So it goes like steps in the you use for going up. So go up in a stepwise fashion, 10, 20, 30, 40, maintain for 2 minutes, and then step down at 2.5 centimeters per for 3 minutes. So this is sometimes that can be asked, so I thought I will include that. And these are all the intraoperative respiratory complications. This chart is given in Miller. So 4 things you have to take. One is capnography, second is pulse oximetry, third is airway pressure, and fourth is clinical examination. Using this, there are 5 conditions which are can be. The first is endobronchial migration of the tube, where you will have no increase in the EtCO2. So PET CO2 will be normal, but the patient will desaturate. There will be increase in airway pressure. There will be reduced air entry. There will be no hyperresonance, no crepitus. So absent air entry or reduced air entry, increase in airway pressure, hypoxemia, but normal CO2, you have to suspect endobronchial migration. Whereas in subcutaneous emphysema, there will be increase in PtCO2, but pulse oximetry may not show any change. There may not be any desaturation. Airway pressure also may not change, and air entry will be normal. There will be no hyperresonance, but crepitus will be felt. If you press the skin, you will find the bubble-like feeling. So that is the diagnosis is subcutaneous emphysema. Whereas for a condition called capnothorax, where carbon dioxide enters the mediastinum, there is an increase in EtCO2, patient desaturates, airway pressure increases, air entry is reduced, and the chest is hyperresonance. Sometimes you may get crepitus also. So then if the EtCO2 rises with desaturation, it is capnothorax. Whereas in pneumothorax, the EtCO2 decreased, it's not raised. Whereas patient desaturates, airway pressure increases, air entry reduces, hyperresonance is there, sometimes crepitus also may be there. So the main difference between capnothorax and pneumothorax is in EtCO2. Okay, so if the EtCO2 increases, it is capnothorax. If it is decreased, it is pneumothorax. And in the massive carbon dioxide embolism or gas embolism, you will have again a decreased EtCO2, patient will desaturate, airway pressures may not change. Whereas here in both pneumothorax and capnothorax, airway pressure will become high, and you will get the mill-wheel murmur, patient will have severe hypotension, and ECG changes will also happen. Okay, so these 5 intraoperative complications: endobronchial migration, subcutaneous emphysema, capnothorax, pneumothorax, and gas embolism. These are considered as intraoperative respiratory complications, which can also be a short note question. And the another point to favor subcutaneous emphysema, as I told earlier, is the continued elevation of EtCO2. So if the EtCO2 not only increases but continues to get elevated persistently, then again that is a confirmatory evidence for subcutaneous emphysema. Okay, so that will close the topic. Stop.